in the area of the actionable goals, we will also have a summary from Justina, one of our panelists, regarding the work that she's come up with from the first transformational dialogue. I'm going to concentrate on the word dialogue because this is the dialogue, and if people can just open up and speak their mind so that we can hear the pain and we can hear the problems and we can then deal with the problems, hopefully. The housekeeping matters are there's going to be interpretations in French, Spanish, and English. So even if it's English, it's two ways. So if you can just select which interpretation you would like. Following that, this whole session will be recorded, and I hope people have no objections to that. Coming to the most interesting part for me is to introduce my colleagues on this platform. We have Dr. Fabio, who's a pediatric surgeon from Brazil, who's currently doing a fellowship at McGill's in Canada on global surgery. We have Kathryn Chu, who's a general surgeon, but from the US, but presently based in South Africa, in Stellenbosch, a very beautiful part of South Africa, which is my home. And Kathryn is going to, she's running the Department of Global Health in Stellenbosch. We have Dr. Rodrigo Lopez from Chile, who's a cardiac anesthesiologist and works at the Catholic University and Teaching Hospital. So as we know, in global surgery, it's just not surgery, but it includes a wide spectrum of health workers that work towards equity. We'd also like to thank Professor Nobhojit Roy, who's a global surgeon, general surgeon in training, but a lot now doing with policy making and has been quite a front runner in the Lancet Commission. Professor Nobhojit Roy had replaced and stepped in quite last minute, so we'd like to thank him for that. Dr. Lupna Samad is a consultant pediatric surgeon in Pakistan, has been spearheading children's needs in the NSOPs in the country and really dealing with the ministry, which is not easy, to hear children's voices and make sure that we're not left out of the policy making for surgery in the country. We have Justina. Justina is a consultant pediatric surgeon from Nigeria, and her focus is on research in pediatric surgery and also embracing global surgery into what we need and what our requirements in terms of global surgery. To me, global surgery, the best way of defining it is public health in surgery. And I think that encompasses all of us because we are surgeons, anesthesiologists, nurses, different fields, but it's the public health that we are dealing with, and which is what separates us from some of our colleagues who concentrate on the surgical aspects of things. So I'm going to open the discussion panel now. So now that the panel's introduced, the three topics, as I mentioned, would be barriers to research, the input from universities and NGOs, and whether HIC influences, helps or hinders in the research that has been done in LMICs. Professor Nobhojit Roy needs to leave in parts of the meeting and will come back. So I'm going to kick off with asking Professor Nobhojit Roy the question of, in the climate of research and the era of global surgery, which has become quite fashionable in high-income countries, what do you feel the influence of HIC research is within global surgery?
Thank you, Professor Lakhoo, and thank you for this opportunity. With this decolonizing dialogue, transformational dialogue, I must say that there is an equal responsibility on both sides. As I speak from an LMIC, I can tell you the research is not a priority for us. So if you are doing research, then clearly you're not looking after your patients well enough. Or if you have a PhD, then it's permanent head damage, and you are definitely probably not a very good clinician. So in LMICs, the way research is looked at, it still is a very low priority. Therefore, having the HICs who have the publish or perish or the strong emphasis on research actually pushes us, drives us, nudges us to do more research. So that's one aspect of it for sure, that a lot of research in LMICs is being driven by high-income countries. The problem beyond that is that the fund flow, the revenue flows for research all go from north to south, which means that the ideas also follows the money trail. So the ideas also go from north to south. And when ideas go from north to south, people also come from north to south. And I think that is where the problem starts off, because then you are not really addressing LMIC problems. You are finding HIC fixes for LMIC problems. So I think that is probably the reorientation, but HIC's driving research is, I think, is a given in our scenario. Over.
Okay, thank you very much. I'm going to move back a little bit and then bring in Justina. Justina, do you want to talk through about barriers to research in your experience?
Thank you very much. Yeah, in my own experience, there have been a lot of key issues that have been barriers to carrying out high quality and good research, as an LMIC practitioner. One of the key issues is the lack of funding. Funding is key to research. Without funding, you can't carry out any fantastic research, to just put it simply. So funding is a very major issue that we face here as clinicians in LMIC when trying to do research. It's just not available. And a lot of times we don't have access. We don't have all it takes to meet the qualifications for some grants I would like to apply for. Like being asked to have worked with someone who is a HIC practitioner for a particular number of years, or collaborated on a project before I can qualify for a grant. So if I don't have that collaboration, automatically I can't apply for that funding. So we don't, so that's one thing.
Okay.
Another thing we face here is that we have limited institutional support. So we don't have the infrastructure, you don't have the support staff that you would need. I mean, I recently worked on collaborated with a high-income country partner, and the support to do a systematic review was tremendous. There was a librarian who pulled all the articles that we needed, and we just went on to review. But prior to that, a prior review I had done, I had to sit down on my computer and pull everything out by myself, and that's quite time consuming. So that also is there. Then there's no time set aside for me here for research, just like Roy had said, because there's not much emphasis put on research, so you don't have any time set aside to carry out your research work here. So you actually pilfering time from different areas, just try and do what you need to do. And last but not the least is sometimes there's a sense of a seeming reluctance of high-income country journals to publish work that's led by an LMIC author. It's seeming, it may not all journals, there are some journals that have sections dedicated to work from LMICs, but there are other journals where it's like you just can't break through into this journal. And the LMIC journals don't have the visibility that the HIC journals have, and that's where sometimes you want your work to get to, and can be discouraging and frustrating sometimes. And so all these points put together sometimes tend to discourage clinicians in this part of the world from going into academic work or carrying out research. Thank you.
All right. I'm going to move on to Lubna. Again, barriers to research. What barriers have you encountered over and above Justina's experience?
Professor Lakhoo, thank you for giving me an opportunity to add my voice to all that has already been said. And I can only start by saying that whatever Dr. Roy, Nobhojit, and Justina have said is very much part of my experience as well. But to add on to that a little bit, I think the core issue is that in LMICs, evidence-based medicine is not a culture. We tend to have agendas that are driven by external donors. For example, when there is a polio drive happening in this country, our health officers or our district health officers can't do anything else because the entire health agenda is around the polio vaccination campaign. And this leads to a donor-driven agenda. And because there isn't a big focus in country on evidence-based medicine, research has always been marginalized. And in some ways you can't blame governments because they are trying to get the basic health needs met and often failing. So to prioritize funding and diverting funds towards research is very difficult. Therefore, we're automatically left to HIC initiatives to fund research in our country, and therefore the agenda is never our own. It's always a handout or a donor-driven agenda. And therefore, the prioritization is often not something that we would have chosen for ourselves if we had a choice. For example, vertical programs tend to get funding much more easily than health systems initiatives. And because surgery is inherently a health systems issue, in order to improve surgical care at any level, you have to do a systems approach. That is why I think surgery will suffer and is suffering more in this funding stream game as compared to other countries. So as compared to other areas of work. So that's one thing. The other thing is that in addition to, it's also a numbers game. When you talk about surgical conditions as opposed to, if you look at children's surgical conditions, they are important. They're very important to all of us and they affect many, many children. But if you talk about the numbers required for vaccination initiatives and the numbers that will be affected by diarrhea or acute respiratory illness, surgery is far less important. And therefore, surgery tends to get pushed back because this is a numbers game in the end, and there is a value for money proposition that many, many donors are looking at. So we tend to get marginalized there as well. So these are some of the barriers. I think Justina talked about publishing in good journals. That's difficult for LMICs, not only because of the content and the kind of work journals welcome, but also the fee is prohibitive for many of us. So while many people in HICs will have institutional support in spending a few $1,000s in getting something published, that's just not possible for our end. And conversely, we don't have open access to publications in many cases. We do not have institutional libraries. So we struggle to find ways in downloading articles or getting access to articles that will help us in simple literature searches as a starting point for our research work. So these are just some of those challenges that we face on a day-to-day basis.
Thanks, Lubna. Shall we go to Fabio? Your experiences?
Sure. So first of all, it's a pleasure to be here, and I really would like to thank you again for the opportunity. I share a lot of the opinion of my colleagues. So I think that we have these three groups, the clinicians, the health providers, the universities, and the policymakers. Our intention is to work for the benefit of the population, but I think that we don't talk with each other. So the policymakers are not hearing the health providers. We don't have like a strong link with our universities after we finish our programs. And for an example, research in surgery is not a priority according to the Brazilian Ministry of Health's agenda. So, and then I thought, so what is missing? And as Dr. Samad has just said, probably is accurate numbers. We don't have data. And I really think that unfortunately, as we are living in countries that are passing like transition stage, the clinicians, the health providers should be the one that will start to kick this ball. So it was what I tried to do. And during this experience, then I realized that, okay, I don't have the proper training for do like a really good research. So I'm going to need help. And then you look for help in your institution. You don't have a lot of people with experience, especially in surgical fields, because as Dr. Roy said, okay, Fabio, if you're going to do research or you're going to be a teacher or not a surgeon. So you must be in the war for you to be considered a value guy. And so I had these problems inside my own community. And then I thought, no, I'm not going to listen them. I think this is important. It's like a kind of mission. And then I started to try to do good studies, but then I have to pay for statistical analysis, translation, journal fees. And then when I saw I was spending like 20% of my salary with like my research, and then this is not sustainable. So I think that is like another important word that research and LMIC is, it's not sustainable. And also we don't have the training for advocate for our results. So then I got some important numbers, and then who is going to listen to me? So I didn't have the contacts with the policymakers. I was not like an important person for the Brazilians' current values. So even that was really hard to translate my knowledge. So I really think that these were my main barriers: the lack of training, the lack of support in my community, the lack of funding for provide good tools, and the lack of knowledge transfer knowledge. I would say like that.
Thank you very much, Fabio. Rodrigo, what are the barriers that you've encountered?
Hi, everyone. Thank you for this invitation. And I'm going to be speaking Spanish, and you will see why. Bueno, si hay algún problema con la traducción, por favor avísenmelo y hablo más lento. Creo que además de las cosas que ya han dicho, de las barreras en términos de entrenamiento y las barreras en términos de financiamiento, hay barreras en la fase de diseño. Yo, por ejemplo, trabajo con evaluación de la satisfacción de pacientes del cuidado anestésico. No son investigación dura de exámenes de laboratorio, sino que es investigación con encuestas. Y uno se da cuenta que no hay encuestas en idiomas que no sean el inglés. Entonces, cada vez que yo hago investigación, tengo que partir por traducir y validar los instrumentos, que ya implica más trabajo. Otra gran barrera tiene que ver con la aplicación de los comités de ética, porque muchas veces los comités de ética siguen aplicando los estándares occidentales cuando el contexto quizás no es el mismo. Entonces, por ejemplo, en términos de consentimiento informado, en Occidente cada persona es la que tiene que firmar. En muchas partes, en el sur de Chile, por ejemplo, o en África, también hago investigación allá, el consentimiento informado, el proceso de consentimiento se entiende distinto. Y muchas veces a los comités de ética de países desarrollados les cuesta comprender que el proceso de consentimiento es distinto. Otra barrera, ya no en la fase de diseño, sino en la fase de publicación, tiene que ver con lo que comentaban de los pagos que hay que hacer para publicar, pero también con barreras lingüísticas. Entonces nosotros, además de tener que pagar todo el proceso de publicación, tenemos que pagar por la revisión lingüística, que eso toma tiempo. Muchas veces el revisor no sabe exactamente cómo se traducen nuestros términos, y ahí nos demoramos más. Muchas veces recibimos la crítica que el artículo está muy bien escrito, o las ideas son interesantes, pero debe ser escrito por algún native speaker, y esas barreras uno se enfrenta constantemente. Yo creo que cada vez debiésemos tener más revistas que estén dispuestas a publicar en idiomas que no sean inglés, o aumentar el peso que tienen las revistas que publican en otros idiomas. El tema lingüístico yo creo que también es bastante significativo. Y al momento de publicar, otro de los problemas que comentaban, que las revistas no les interesa quizás publicar nuestra investigación, tiene que ver con cómo se evalúan muchas veces nuestros trabajos. Me ha tocado revisar artículos en que el proceso de revisión no es tan ciego. Yo sé que los artículos vienen de Ghana, de otros países en África, por ejemplo, y eso eventualmente puede despertar algunos sesgos en algunos revisores, y hay que estar muy conscientes de ello. Y también parte de lo mismo tiene que ver con las personas de países de ingresos medios y bajos. No tenemos las mismas redes que la gente de países de altos ingresos. Uno no sabe, no conoce a los editores, por ejemplo, no sabe por dónde va la línea editorial, y eso también nos implica más desafíos. Muchas gracias.
Thank you very much, Dr. Rodrigo. Kathryn, I'm going to bring you in here as you represent the university. You've heard all the barriers and, having experience in both areas, HIC and LMIC. What do you think the universities can provide to come to some sort of help or kind of deal with these barriers?
Thanks, Kokila, and just thanks to Lifebox for the opportunity to speak. And just been some great ideas that have come through. So I think that one of the issues that I think that LMIC universities can help with, but one of the issues is that really in LMICs, there's, especially in surgery, anesthesia, obstetrics, there's no research pipeline for trainees. So, when you do your residencies, there's no sort of surgeon scientist kind of mentality. Everybody's being trained to be clinicians. I think Dr. Roy mentioned, because we're so short-handed on the coalface at the front lines, that's the focus of everyone. But for example, in the US, and there are mechanisms for many residency programs to have 1 to 5 years of research training embedded into the surgical residency, so that when the graduates finish, they have had formal research training, which allows them to compete on an equal playing field with high-income country partners. And so that's where I feel like here in LMICs we're lacking. A lot of what folks were mentioning is that they don't understand the research design. How do you use validated tools, especially in health systems research? So as surgeons, we might understand how to do a quantitative audit on numbers. How many operations have we done and how many anastomotic leaks? But how do we look at qualitative studies? How do we do systematic reviews? And I think that kind of methodology is missing. And also, it was mentioned, but I want to emphasize that having mentors within your own field that are also scientists is really important. If you don't have those mentors in the US, there was always the ability to find mentors in your field. And so I feel like then in LMICs, we're always on the back foot because through training, we never got it. Now you're a junior faculty member. How then do you get established? Because now you're busy as a clinician. And then you might have a very generous high-income collaborator who says, yes, we want to collaborate with you. What's your idea? What is your, how do you want to design this study? And actually, then you don't have the tools to do so. So I think to answer your question, Kokila, I think that here in LMICs, we need to have a mechanism where if not all the trainees, but some of them who've expressed an interest in having a research career, that we allow them the time and give them the training to do so. And I think that partnerships with high-income universities can help that. I know Oxford offers some training in research methodology that could be free online. Now all the virtual platforms, I think, is a game changer. And being able to tap into high-income funding, perhaps just to get the pipeline started, but then you will have a whole cadre of faculty like Justine, like Pablo, who can then be the mentors for the people coming through. But I think that's kind of where we need to start. Thank you.
Okay, thank you. What I'd like to bring in is also having experience in both ends where, personally, all my research had to be done on my own time, and knowing how hard it is, and you have to just work double the time to get it. But coming into the HIC camp at the moment, there is a fundamental problem within the HIC system as well, because your input is judged by the impact factor of the journals you put your articles into and the amount of funding you would get. And coming into global health funding, so you find that there are countries like the US and UK, Australasia, putting in large amount of money into global research. But if you actually look at the detail of where that money is kind of directed towards, it's towards the high-income country individuals. So when you look at the grant applications, which I've had the opportunity to do, if you put in that more than a certain amount has to go to the area where the work is going to be done, that grant gets rejected, because the way it's designed, that the money actually stays in the HIC. And then, so even this whole factor coming that, okay, yeah, we're coming from the HIC, how can we collaborate? But the collaboration is actually one way. And you just have to look quite deep into the core, the fine print. The second thing is you find that the very high impact journals look at statistics, and almost, I think 75% of the reviewers are statisticians rather than clinicians. So should we also be, which is a barrier, and I'm talking about a barrier from the HIC point of view now. And when we come to talking about how can we change this, I think I would like to direct that to, why don't we approach these journals that the whole impetus is wrong? That let's look at articles that are going to make an impact as the judge rather than the statistics. And we all know there are thousands of statistical models, and you choose the one that's going to fit your data. So having the experience from this end, Lubna, I'm going to come back to you. What's your view when HIC people do come in to say, look, we'd like to collaborate with you? As I said, this is a transformational dialogue. So be very honest about the feeling, your first reaction.
Kokila, I'm never anything but honest, and that gets me into trouble ever so often.
Which I like.
But, I'm going to build upon what you've just said with an example. I read this article yesterday in Nature Medicine, written by 3 African doctors, surgeons, doctors, not surgeons. And they talked about the malaria initiative and how the funding stream is being organized in malaria research. And they said in 2017, and I'm quoting these figures because these are, what's alarming about them is that they're typical. This happens all the time. In 2017, $1.1 billion was allocated to malaria research and implementation in Africa with 3 HICs. And when they studied using a global metric system and they studied how these funds were utilized, 81% of the funds stayed within the donor countries. 18% of the funds went to NGOs and international consortium members, whereas only 1% of the actual research funding reached African researchers. And the contention was that nobody understands malaria in Africa better than Africans. They've been facing it for decades and they know how to manage it. So just the way these funding streams are structured is probably the root problem lies in just the way they're structured. And as Kokila, as you rightly pointed out, it's inherent bias that is present in the way these grants are laid out, the budgets are required to be set up and so on. So the money stays in HIC. I think if I were to look at it in a very interesting way, the metric should be that at the end of X number of years of collaborative research, how many LMIC researchers are able to do independent research, get independent funding, design studies independently, and find solutions independent of HICs. So I look at the collaboration between LMIC and HIC partners as a capacity building exercise rather than a lifelong hand-me-down. So if you look at it in the dynamic of, in a finite amount of time, I have to make this particular partner of mine capable of doing this on their own. And if that is your outcome metric, when you talk about the way research funding and research capacity should be planned, that probably is the way to go. And the fact that that isn't happening in most settings for most global health agendas is alarming in itself. I think in global surgery, we are poised very differently. we have very little funding for global surgery. That's one of the problems all of us are facing. And that gives us an opportunity to start right when the funding does start. And we're all hopeful that this will be seen. We're all pushing for it to be prioritized. Once the funding starts coming into global surgery, we should be prepared to make sure that it is fairer, the way this funding is structured, the way the capacity building is going. I think the biggest plus, and again, as I've said before in other forums, I'm an optimist by nature. The biggest positive that I see here is that global surgery has some of the most equitable partnerships happening in the global health arena. So, GICS and, the way you've set up GICS with a very equitable structure with a lot of emphasis and a lot of focus on bringing up LMIC partners on an equal footing is an excellent example. And there are several other examples of the way this has worked out. So personally, I've had a great experience because the partners that I've worked with in HICs have been extremely fair, extremely cognizant of the fact that we understand issues in our own settings better than they do, and they've been very responsive and receptive. Perhaps it's because I've only chosen to work with people who don't have an attitude issue, and that helps. But I think that is one of the key things that we should all be focusing on as we work towards developing funding streams and research agendas within the global surgery arena. Sorry, that was a bit of a longer comment than you'd bargained for, Kokila.
No, I think that was important to outline it the way you have. Fabio, would you like to respond to this?
Yeah, sure. So I have some more collaborations with high-income countries. Actually, I'm leaving one collaboration as well. So I can give my examples. I think that examples are always good for us to in dialogues, as you said. So the first, when I had a collaboration with the program Global Surgery from the Harvard team, and they invited me to collaborate. And I'm going to speak about good examples as well. So one of the things that they demonstrated to me is like, we want like a local partner in Brazil. So I thought that this was sensitive at that time. So we are going to send our tools, so the medical students that you need to do the analysis, to help you with the translation. So this was really beautiful at that time. But I also, with the time, I realized that this would not be like, as Dr. Samad told me, like would give me like independence for me, for my follow research. And I also like to add for these students that are coming to Brazil, I want to teach them with my view how I would like to work with that data. So that's the reason I tried my second collaboration, and I came to Montreal. So I have to came here to receive like proper training and in global pediatric surgery, because currently in Brazil, I can say that we have like 3 really researchers doing like global surgery. So it'd be really hard to have all the training there. So then, and I saw like a comment here of Moises, I believe that. So I have to spend all my money to do research, and actually this is what I have to do in order to bring this knowledge after to Brazil. So I think that we have this really 2 kinds of collaboration that I lived with high-income countries. One is like the short-term missions. I think that's important. They go there, make your voice heard in the beginning, and then you have to look some things for being independent, and then to have proper training in high-income country can be like a solution. But I also think that if we have the funding in Brazil as well, I would be happy to do the training there with my people, with my community. And I also think that this could be a solution. I believe that most of my colleagues that would like to do research, they don't want actually to move. They want to live with their family, but they don't have their funding to give up one of their jobs. So they have to work in 3 different hospitals because of the political stability economic in Brazil. So they are not confident to work only one hospital. So they have to survive as well. And there is no time for research, even for those that think that's important. So I also think that would be like a key thing.
Okay. Rodrigo, regarding collaborators, I mean, Dr. Lubna mentioned that she chose her collaborators and it has helped in certain aspects. And we've heard Dr. Fabio talk about that if we did have the funding, we could do the same in Brazil without needing to move out. Have you got an experience, or could you talk us through your experience with collaborators?
A ver, la verdad es que Chile es un país que desde el punto de vista económico no está calificado como país de ingresos medios, sino un país de altos ingresos. Y eso, de alguna manera, cuando nosotros hacemos colaboración con países de bajos ingresos, nos pone en una posición compleja porque no somos Estados Unidos, no venimos de Europa, pero no tenemos la misma realidad que ellos. Y ahí uno se da cuenta de cómo reciben en muchos países a la gente que viene del mundo desarrollado, por decirlo de alguna manera. La desconfianza que muchas veces hay, lo que comentaba Lubna, de la agenda. ¿Quién es el dueño de la agenda? ¿Por qué estamos investigando esto? ¿A quién le importa este tipo de investigación? Nosotros personalmente, como no tenemos el pasado de haber sido una potencia colonizadora, hemos tenido un poco más de facilidades para acercarnos y poder efectivamente dialogar cuáles son los temas de interés para nuestros socios en África. Y en ese sentido, por ejemplo, hace algún tiempo creamos un programa de entrenamiento para enfermeros y hacer los enfermeros anestesistas de procedimientos muy simples, muy conversado con ellos cuáles eran sus necesidades. Y el problema fue cuando quisimos reportar esos resultados, mandamos este trabajo, esta publicación, a una revista que sabíamos que publicaba cosas o trabajos sobre entrenamiento en anestesia en países africanos, y nos pidieron muchas veces cambios mayores, hasta que finalmente lo rechazaron. Y una revista que era tema para ellos publicar este tipo de cosas. En algún momento, algún amigo de un país desarrollado me dijo, mira, esto no lo vas a poder publicar nunca en Estados Unidos porque es demasiado novedoso y no hay ningún norteamericano entre los autores. Cambia un par de cosas en el artículo, cambia esto, ponme los agradecimientos y mándalo a alguna de estas 3 revistas en Canadá o Europa. Y pasó inmediatamente. Entonces yo puse en el chat el comentario de It's all about politics. Creo que los intereses personales afectan mucho. Y eso yo creo que en la medida en que los países más desarrollados sean más honestos en transparentar cuáles son sus intereses en la colaboración, ayudaría mucho a hacer una colaboración más honesta. Cortito, pero concuerdo también, como dijo Fabio, que no todos son malas experiencias. Hay que destacar también que hay mucha gente que tiene la formación, hay institutos que tienen los recursos y tienen la voluntad de efectivamente comprometerse con instituciones de países de ingresos bajos y así potenciar la investigación. O sea, también hay un lado bueno en la colaboración y es posible.
Thank you very much, Dr. Rodriguez. I'll bring Justina in here. Justina, do you want to talk us through some of the probably successful collaborators and some not so successful collaborators?
Well, thank you very much for this opportunity once again. I will say that I've had some very fantastic collaborations with partners from high-income countries, some on the panel here, and actually have some mentors as well. And very productive, like when I talked about the systematic review, it was a fantastic learning process for me. But at the same time, I would say that there are other collaborations that we all see around that have not been very beneficial to low and middle income countries. And one of the things that drives these collaborations is the fact that for some countries in LMICs, if you are in academia, if you're a teaching professor and you're also a clinician, you would need publications for promotion. And that is what attracts people to be part of these collaborations, because the name gets on the authorship, and then that adds to your points for promotion, right? But at the end of the day, it's actually data collection and then getting published without real capacity building for research for the local collaborators. So I think that's where the flaws lie in some collaborations. Yeah, there are some collaborations that include capacity building right when the research is being designed, but there are others where the participants from LMIC have just simply collected data and there's been no real capacity building in that regard. I think just so I don't repeat what other people have said, I'll just stop there. Thank you.
I think it's like Emmanuel Makasa put it very succinctly, that we had gold mining, diamond mining, and now we've got data mining taking place in our countries. And he put it very well. Kathryn, what's your view on collaborators and how can we make that different?
Thanks, Kokila. So I think that one thing to take a step back for high income faculty who want to do equitable global health research, and I think there are definitely those out there, their academic promotion system is not set up for them to support what we would consider equitable collaboration. So I think it's sort of mentioned, for example, for their own promotions, they need senior and first author publications. They need to be the PI on grants. But if they say, for example, they want to set up a training program where they come and do intensive on-site research training for us in South Africa or in other African countries, at the end of 5 years, it's hard for them to put that on their CV, and then that gets sort of overlooked. Or if they actually want to help us write a grant where we are the PIs, that's also not rewarded for them when it comes time for their promotion. And so there is a group now as part of the CUGH, the Consortium of University for Global Health. And it's actually a really interesting committee within CUGH of quite a lot of the deans, mostly it's North American universities, who are trying to get this into the attention of kind of their university structure. So especially those working in global health, could there be a different criteria for promotion? Could they count the number of postdocs that they have enabled for funding for an LMIC, not the number of students that they send to an LMIC? Because I think one of the tensions at the moment, and I think someone else had mentioned this, is that there are many high-income countries that want to send their students and residents to us here in South Africa, but we want our own folks trained, and we want them to just give us the money to train them. So of course they don't get rewarded for that. So I think that I think all people are all good people. But if the structure was better set up so they would be rewarded for these equitable collaborations, I think that moving forward, it would also be helpful. And I do think that some of the high income funders are allocating more money to LMIC-led projects, or to at least have to have a co-PI. Some of that might be tokenism in the beginning, but I think at least it's a mechanism for LMIC researchers to sort of get in the game. I think in an ideal world, we would have our own funders. So South Africa, the Medical Research Council could fund our own people. But at the moment, especially in this current economic climate after the pandemic, that's sort of not as possible. But I do think that if somehow high income funders could just say that it's an LMIC-led project, then that would also be really helpful and be one less barrier. Sometimes, for example, for UK, US funding, an LMIC researcher would have to find a partner in the US and the UK. And some people, like many of us on the call, do have established collaborations, but many don't. And so if you are a clinician working in, Brazil, Chile, South Africa. How do you start out and find that collaborator right off the bat? So I think sometimes those aren't as easy. Thanks. I'll stop there.
Thanks, Kathryn. It looks like there's a dichotomy where the demand for funding in the higher income country institutions is based on the grants and the PIs, as you spoke about. But when it comes to global surgery research, and I have personal experience with that, it doesn't gel for the toxic environment you see in academia, where it's very competitive. And when they ease that collaboration, it's like, who's going to benefit? Whereas if we are going to set the standard and drive it, then we drive it from the platform that this is to create capacity building, equity. Just keep that word equity in our mind all the time. And if we keep harping that, it will sink in somewhere. And if we don't start doing it from now, challenging our funding bodies from the HIC to change the paradigm, to talk to our high impact journals, to change the focus when it comes to global surgery. What is important? Is it the impact of what the research has unfolded, or is it all the Western style data collection and trials? And I think that is a task we need to think about by the end of this sessions that we're going to have. So it's time now to open the meeting up to questions. And we'd like to welcome questions from the audience. To any of the panelists, or just a general comment. You could put them onto the chat and I'll be happy to read them out. So we have a comment here from Joan to say that this can probably be a political commentary, but probably one of the most important, important thing that the COVID-19 pandemic has taught us is that the healthcare is a global issue. HIC and LMIC should work together to fight major global health problems. It is not possible to separate healthcare and healthcare research because it involves all of us. And I think that's a very important thought process, because I think the whole concept of vaccine, of where the vaccine has been kind of researched and who's getting the vaccines for protection, it's another can of worms that we can open. But basically saying that if you don't keep the world safe, you're not safe. So as much as there's a grab for the cherries in the high-income country, there's no safety in a high-income country if the world is not safe. Kathryn, I think you've got your hand up.
Yeah, thanks, Kokila. It's actually on a different point, so I don't know if you wanted to continue with that thread first.
No, you could. Just bring in the point while I read some of the chats.
Okay. So my comment was also that, sometimes we've been talking a lot about LMIC and then not versus, but in high income kind of challenges. But I also wanted to bring up that sometimes within LMICs, translating the research to what the policymakers want to listen to is always not so easy. So I think another panelist had mentioned not using evidence-based care, evidence-based solutions to change policy. And I think that I find that is one of the challenges here, particularly in South Africa. But even if universities, we can gather a lot of data, but if we present the data to the policymakers, it might not be so interesting. And I think one of the issues is that surgeons, anesthetists are only learning to speak the talk of public health just recently, and policymakers listen to public health specialists, not so much surgeons. And so if we learn to speak the talk, that might be helpful. But also I sort of find that we can do lots of research, and we can even get people in high income countries to be interested in our work, to invite us to their conferences, but in our own backyard, our own national policymakers may not be so interested in the same results. Thanks.
What Kathryn is highlighting is the politics. Is there anybody else from the panel who would like to come into this discussion?
Yep, I just would like to comment a few words that I think that is really important. And it was interesting for me. I had the opportunity to do like a global health course here in Canada from the perspective of the high-income country. And it was really interesting discussions. And one of the things that I thought that was most hard for my colleagues here to understand is how to work local in a country. This means to be global. Yeah, it's so as like also addressing the comment of Juan, that it's hard to convince that if the government, or just an example of Canada, would like to work on children violence prevention in Brazil, this in the long term will reflect not only in Brazil, but in Canada, in other South America countries, and we will have this better world for everyone. So we must believe on this as a high-income country to give more funding opportunities for these projects, as a low-income country to believe in our projects as well, that if we do research there locally, it is important for everyone.
Okay. There are a few comments on the chat. I'll bring Dr. Rodrigo in first. You've got your hand up.
Sí, comentando un poco lo que dijo Kathryn, estoy de acuerdo que la investigación no es tan valorada en por los políticos de nuestros países. Ahora, yo creo que pasa en todos los países, no solo en los países de bajos ingresos. Pero creo que también son responsabilidades compartidas. No sé hasta qué punto nosotros como investigadores ayudamos a los políticos a tomar decisiones basadas en la evidencia. Muchas veces investigamos lo que nosotros queremos investigar. Y después, así que la pregunta vino de nosotros, no de los problemas políticos del país. Y después la manera en que comunicamos nuestras decisiones, las hacemos a revistas científicas y no sabemos cómo llegar a las personas que toman las decisiones. Yo creo que este gap, este espacio que hay entre investigación y políticas públicas, es algo que también deberíamos trabajar no solo en países de bajos ingresos, cómo estas dos realidades se comunican más y de algún modo hacen que la investigación sirva para resolver los problemas de la gente y no solo nuestras inquietudes.
Justina? You've got your hand up, Justina. I think she's frozen. We'll go to Lubna.
Thank you. I think it's very important to understand that while, I agree with Kathryn in that our own governments, our own people don't understand the value of the research we do. Again, one of the reasons is that even if they were to value it, if the agenda is donor-driven and the donors are international or multilateral donors, and the agendas are set in Washington, D.C. or European or Geneva, then obviously there's not much sense in convincing our own policymakers to some extent. It's a catch-22 situation. However, I think it's also important to recognize that a lot of us, even while we're trying to overcome while we're talking about decolonization of global health, many of us are still living in a post-colonial mindset where something that is created and tabled in an international setting is more valuable and to be taken much more seriously. I think one of the things we realize that while we may be experts on this panel and other international forums, often our own countries don't reach out to us for our own expertise or understanding of a topic. So there is a very clear, if something comes from Harvard, for example, the brand name will speak a lot. Or if something comes from Oxford, that means something. But if something comes from an understanding that we've developed in a slum population of Karachi, that will not be as acceptable as the solution, as opposed to something that comes with a foreign packaging. And I think that's a post-colonial mindset that is unfortunately prevalent in many, many countries of the world.
Okay. Thank you very much, Lubna. I think we've lost Justina. But I think the point has been taken that there is collaboration mismatch sometimes. And what you pointed out is that in our own backyards, there isn't a understanding or an appetite for looking at what we're talking about. And I think the Lancet Commission kind of did that for surgery, where the sole purpose of what they've done is that they've added surgery as a global health problem at the front line. And that task has been done, and I think that's really good that it's recognized as a global health problem. But we need to look at beyond that. And beyond that is the problems we are talking about now. That I think is a simple thing, like you mentioned, that there's a lot of money going into vaccination or TB or malaria. We now have statistics that there are more deaths from trauma, which is surgically related, than it is from HIV, TB, and malaria all put together. So those data are very powerful in directing our policymakers to say, hang on, let's do something about trauma, let's do something about transport to make that better. There are a few questions up here talking about, do people know where to go for funding that will be, LMIC and to the point of applicable, friendly. Do people know of mentors or mentees that can work together? Problems with inadequate data collection because of lack of education regarding that, or no training regarding data collection. So there's comments about poor institutional policies. And I think we need to think about that there's no quick fix with anything. We know this is the problem. We know that we need to drive the safety of people before we even look at research. But yes, you need both of it. Fabio, did you have another comment? Or yeah?
Yes, so I would like to answer one of the questions of the chat that I think that is really important. That Ayla has asked, I'm just going to read her comment. I agree, and I'm really thankful for these incredible insights. As a recent graduate from LMIC with interesting research, I feel a dilemma. If I continue my studies in a high-income country to build knowledge, or stay and try to change the reality I live in. So I think that this question is really important because a lot of people that I think that is here lived that question. And I would answer you, Ayla, that really doesn't have like a correct answer. I think that both directions is correct. If you have the good reasons that you want to go to the high-income country to do more training, and if you stay, but your research will be directed for the place where you come from, this is also like a correct decision. If you'd like to stay, I think that you can work for your community independently of where you are, and especially if your countries live a transition period of, so you can't sometimes just trust in your government, in your economic policies. So there are some cases that people can do more in a high-income country than live in your local country for their countries. So this is, I think that you are going to feel your direction, your life.
Rodrigo?
Sí, quiero agregar algo en la misma línea de lo que dijo Fabio y Lubna para contestar esta pregunta. Desgraciadamente, como dice Lubna, vivimos en países con un pasado postcolonial en que lo que viene de fuera es mucho mejor recibido. Y mi estrategia, o lo que me resultó a mí, fue ir a estudiar afuera. Y de esta manera tengo más credibilidad en Chile. Y me es más fácil, por ejemplo, presentar proyectos de investigación, conozco muchas más fuentes de financiamiento. Durante mi formación también traté de aprender cómo acercarme a los tomadores de decisiones. Entonces yo creo que una estrategia muy buena para cambiar las cosas que pasan en nuestros países es formarse afuera, aunque quizás uno no aprenda tanto, pero va a tener el peso de, yo hice el doctorado acá, yo hice un magíster acá, en un país desarrollado, voy a conocer a gente, y eso hace que los procesos de cambio que comentaban, que toman tiempo, sean un poco más rápidos quizás.
Right, thank you very much. Justina, do you have any comments? I know you got lost.
Yeah, I did. I was trying to make a comment initially before I got lost on speaking to policymakers. And one of the things we learned in Nigeria here working on the NSOAPs is that we have to speak the language that they would understand, like we're talking to our scientific colleagues and also those who are to journals, right? And one of the things, what we tried to do was look at what other specialties were doing and getting heard. HIV, tuberculosis, they get listened to, they get their agendas taken seriously. So how are we going
I think Justina's
to
frozen.
get our, even though, okay, I'm sorry, I got frozen, to get our voices heard, even though we're dealing with surgical issues. So dealing with the media and asking them, how can we get our voices heard regarding these issues and the problems that we're facing here in surgery? And also I'd like to say that areas we're facing, about the things we think are not right from high income countries, but we also need to have a meeting point between high income countries and low and middle income countries so that we can all benefit from the collaborations that we're having. Especially with, like someone mentioned, everybody has a good heart. Everybody wants to do something good for the other person. So if we have a meeting point where we can actually look at these and determine how everybody can benefit from what is on ground, and it being skewed towards one direction. And I believe with dialogues that we are having, we're coming to that point where we'll have good dialogues between both partners that would lead to.
So coming to the next part about having actionable goals, I will kick off with a few ideas that I've put down in mind. That one of the things that I've seen worked quite well in Johannesburg in South Africa, where again, if you work at Baragwanath Hospital, which is based in the low income area of the city, is that its pediatric surgeon, we working with my colleagues there, we decided that each trainee must do an MEd. And if they do an MEd, that links them with the university. So it embraces the university. A project has to be done. You do the fellowship, but you also have a university degree. And that kind of infused research into the department because it was locally led. The second point I wanted to make is that in the high income countries, when you look at big funding bodies, it's very prescriptive. And the success I've had is to go to legacies, and there are families, there are a lot of donors, people that have a lot of money and feel they want to contribute. And approaching those legacies is quite helpful because there's no strings attached to that money. And as a collaborator, if you say, like, what is the need, and develop researchers, develop a research program, develop a PhD program in the low-income country with funding sources and resources catalyzing it, like enzymes, does work. It has worked in some countries. And in the third point I wanted to make is that maybe we should have a strategy to encourage these high impact journals to look at impact factor of the, not in terms of the statistics and the analysis and the methodology, but look at what changes has it made in the country. And if it's impactful in changing the country, then that's the article that should get its highest accolade. These are just 3 pointers I thought I'll bring up, but open again to the panel. Fabio, would you like to talk about action goals?
Sure. Just because I remembered like something related to the journals, so I'm going to share some experience with the College Brazilian Journal of Surgeons Journal. So it's really interesting because they are indexed in PubMed, and you write your article in Portuguese, and then if they accept, they will automatically translate the article for English, and then you have the both versions of the articles in English and Portuguese. So with this example, what I think, we have these big journals, they have like editors from all the world. I think that would be really easy for them like to receive the article in different languages. The first editor will be like someone that speaks the same language, a pre-approval, then the journal will translate the article for other reviews. So I think that is really a feasible solution that could change a lot the research in LMIC. The second thing that I would suggest, like I'm always trying to think simple solutions. So for an example, we have this small research group of medical students in Brazil of global surgery. And after I'm going to write my email here, if like I saw that there are some medical students from Brazil that would like to contact me. So why not like funding a statistician, like the role of NGOs and other institutions that would like to fund local research. So fund the 1 hour of a Brazilian statistician, for an example, for this research group, just to discuss some project and also translation in initiatives. Because I think that for us there, with the experience that I had so far, these were like the 2 main barriers to accelerate the process of research. So I think that would be like simple initiatives. And it's also important, thinking about the bilateral collaboration, to give voice, especially for the students. So I thought that sometimes the NGO comes, look for us, but it would be good to involve the students, to give them voice, to say to the students, oh, you are part of our organization as well. They would feel so full of energy and power. Okay, I'm a member of the Lifebox, I'm a member of the Geeks, PJSSC. And when there is a time for an interview with like a big policymaker, okay, I'm going to do the interview, but can you give like 5 minutes for this local student that want to be heard? So I think that would be simple solutions. Yeah. Okay. Thank you.
I think the pandemic has been really good to embrace medical students into research, and globally I've had them, I was impressed and even blown over by their enthusiasm. Kathryn, any actionable goals that you'd like to share with us?
Yeah, I think I have sort of 3 points around this. I think the first would be from working from within our own countries to make the change. And so, Kokila, you mentioned the MEd students. And I think that one of the issues that I find is the limitation with the MEd projects, at least from the universities here in Cape Town, is that the MEd needs to come up with their own independent project from start to finish. And given the time constraints and the things I mentioned before, often that project isn't that impactful. But if they were able to tag onto a bigger project, so for example, I see Bruce Bickert on the call, he has a much larger multi-institutional trials going on, like his ASOS study, the African Surgical Outcomes Study, where if the MEd student could tack onto a larger study that's well thought out, that I think that then they would benefit from learning a lot more research methodology than just working on their own independently with their own mentor who may or may not be that well-versed in research. I think that would be a change from within. The second thing is, if there's any way to change the funding mechanisms from high-income countries, where applicants from LMICs, if the funder thinks they have a good idea, instead of making them spend thousands of hours on an application with a 1 in 500 chance of getting it without any connections at all, could they not accompany the person to help them write a good proposal? So, I sit on the board in MSF, Doctors Without Borders, and I'm on a committee that gives funding, so internal funding for innovative research projects. And, once the group comes up with an idea, the funding committee accompanies them to help them write the proposal as well. And so they don't just sort of say, okay, well, you got an idea, pitch it, and then it will say yes or no. It's actually like from the beginning. So if there is any way the funders could have a special pool where they actually mentor the researchers and say, well, I think this is a great idea, but we don't understand your research design at all, but we will help you and work with you. And I think that could, because it's all part of the learning process, isn't it? It's not this black box of like submit a grant and then the chances are, even if you're a really good researcher, the chances aren't great. So how would an LMIC novice researcher fare? And then the final thing is, how could we find other solutions or partnerships between LMIC and HIC groups? And so Kokila, you mentioned maybe not having the journals accept such statistically perfectly sound research, but also I think that if there were groups, maybe a group like LifeBox would want to initiate it, where a researcher could come on and get 15 minutes of other people's time, present their idea, and then just get help with the research design. Because I often find that if you don't design it well, and then you go way down the line, 2 years into your research, and at the end, someone said, why did you do that project, Kathryn? It was never going to be publishable, and I had no idea. And so perhaps if there's just a platform where the person only has to, or the group just spends 15 minutes on each person's presentation and says, oh yeah, but have you thought of this, or do you need a control group, or if you're going to do a qualitative study, there's this great framework, and that's it. But at least there's that input that could be free, and it could be a great way to start collaborations. Thank you.
Thank you very much. Lubna, have you?
I think Kathryn has really hit the nail on the head with some of the mechanisms that she's described. This need for a mentorship rather than it's really the I think what Partners in Health calls the accompanying and walking together rather than above or below. And I think when thoughtfully mentored, the LMIC researchers are, stand to learn a lot from HIC partners if it is done right. And I think that two-way communication should be strengthened. I think overall there has to be a conscious effort to track, because as we said, the system needs to be realigned. What is the system hoping to achieve? Because a lot of us are basically caught within a much bigger framework that at an individual level we can't change. Where the fundings go these are political decisions, often not decided at the level of academia, but at the level of political will at government levels or at multilateral donor levels. So the ability to use the reach of our HIC partners into realigning that, evening out the playing field a little bit. That is important. And I think things like groups like the G4 Alliance could maybe formalize the process, for example, to say that let's track how many people worked with LMIC partners, how many were able to build in-house research capacity, how many were able to graduate researchers through XYZ programs, fund people through meaningful research training, and so on and so forth. So actually have something transparent out there which measures this effort in a way that levels the playing field, and those could be macro steps that realign the opportunities, realign the funding streams, realign the way knowledge and partnerships are structured. That has to be rethought through, in my opinion. I know it's very macro, I know it's very umbrella, but sometimes you need a little bit of that top, grassroots up, and then a lot of this umbrella approach coming in to make things connect in the middle.
Sometimes the answers are there internally. I mean, my experience is in Tanzania, where I've been working for 20 years, just supporting in capacity building, is I came across a public health worker in the hospital who I embraced and got legacy money to support, who works with the pediatric surgery team, and the research output has just shot up because there's internal input, there's internal questions, the expertise is there, it's within the country. We just need to find it. And I think in surgery, because we are busy in theater a lot, embracing our public health departments in collaboration for the studies we need in surgery is also one of the answers that, that can help. I think what I'm going to do is I think there's a point where Justina needs to feedback on her first conversation. And then I will open the platform up for some questions, maybe in the last 5 minutes. And I would like Kitty and some people to help me from the platform, because the chats are rolling so quickly, I can't read them in time. So if you could just help me with some of them, or the panelists could just help me with some of the questions, like Fabio did. Justina.
Oh, yes, please. Thank you very much. We have been discussing transformational dialogues here, and the whole aim is to have a dialogue on the problems that exist.
I think we've got internet problems. While Justina's coming back, we've seen Nobhojit is back. Nobhojit, we're at the point of what are the solutions? What can we do to change this paradigm of barriers?
Thanks, Kokila. I have a very short point to make. I moved out of the operation theater over to the dark side of policy making. And I think Rodrigo said it and Lubna said it. And a lot of people.
One of the things that we.
Justina, let me just finish. I just got started while you're off. So it's about the policy maker and the academic. We had a lot of discussion, and I know we're a bunch of academics, and we are all sitting in the surgeon's room discussing the policy makers who don't get it. And I can assure you, we sit in the meeting rooms of the policy makers and say the same thing: the surgeons don't get it. And I'll tell you what you don't get as I move over from academia to the dark side, is that when a minister says that I've got 2 years to go and give me a solution today, and I can tell you within 2 years we can do something differently. We say, here's our plan for 2030. Here's our plan for 2035. This is going to be the grand surgical world. And he says, I'm going to be here only for 2 years. That's my tenure. So tell me what I can do in 2 years. And we're like, we don't know. We'll have to do a pilot, and we'll finish the pilot in about 6 months. And then we will get our results in the next 1 year. Then we'll do statistical analysis, and we will definitely give you a solution in 2 years' time. I mean, what use is that? Because the minister is gone in 2 years' time. He wants a solution now, and you academics are so thrilled with your methodology and your clever little p-values that it's of no use to the ministries, unfortunately. How do you get academics to walk hand in hand? Accompaniment is the basic key, and that needs real world research. It's a little far away from the research we do, and I would like to stop at that. But here's a policymaker and a surgeon in the past life saying this to you. Oh.
Don't you think that it's a worldwide problem where health and education should not be a political tool, that it should be out of the stream for campaigning, for political gain? Because what you're describing is exactly the problem, that the time period is too short. By the time you implement what you think is the correct policy, the government changes, and they change everything. So my thought process is that if health and education is kept out of politics and has its own stream, we might see some success. I think, Rodrigo, you had a comment?
Sí, a ver, dos cosas. Uno, lo que acabas de comentar, que si bien estoy de acuerdo, creo que la investigación y la educación no pueden depender de la política. Hay que reconocer quiénes son los tomadores de decisión. Y yo creo que en inglés tienen esa diferencia muy buena entre politics y policy, que en español no existe, es una sola palabra. De algún modo tenemos que trabajar por políticas educacionales y de investigación más sólidas, que sean ojalá más independientes de la política de voto. Y eso implica, como recién decían, conocimiento y es área de investigación. ¿Cómo hacerlo? Es una pregunta que tenemos y que somos científicos, podríamos intentar también resolverla. Y mi segundo comentario, independiente que estoy muy de acuerdo en que la mentoría es algo clave, que ayuda a solucionar muchos de los problemas, creo que también tiene que ver con asumir quizás estos sesgos inconscientes. Hemos visto en Estados Unidos todo el peso que tiene el tema racial, por ejemplo, y cómo la policía ha tenido que enfrentar estos sesgos inconscientes y hay maneras de enfrentarlos, de identificarlos primero, cómo se trabajan. También en Chile tuvimos hace poco y lo seguimos teniendo, temas de género, el machismo, cómo se estudia, cómo se enfrenta. Creo que tenemos que hacer la comunidad científica y particularmente los editores de revistas, que revisar cuáles son sus sesgos culturales inconscientes, de modo de evitar que al momento de evaluar algún artículo, el peso de viene de Pakistán, viene de Congo, viene de Perú, sea lo más reducido posible. Porque si bien nosotros pensamos que es principalmente ciencia, en la práctica sabemos que nuestras decisiones están condicionadas por muchos otros factores. Así que creo que también eso es algo que hay que hacer.
Thank you very much. Just in approaching the panelists, are there any issues on the chat that you'd like to bring up? There's one that, what changes would panelists most like to see made and by whom? I think some of them has been answered, but is there anybody who would like to take that up? So we've got 6 minutes. I'm opening up at this point for questions from the audience.
So I think that the pandemic brought some lessons and opportunities as well to make more meetings and to meet more people. I was just answering like Muhammad here that suggested like a global network where you can have support for research. So GICS did this initiative once, and the problem was that time that GICS is the global initiative for children's surgery, was that the adherence was low. They were open for you to discuss any kind of project, and also the language was like a barrier. So for some researchers, so I would suggest again like this opportunity to funding the local research groups. And when I say funding local research groups, would involve statistician for them, maybe translations and fees, journal fees would be like, I think, a good strategy to boost their research in LMICs.
Any other chats that people can pick up from the panelists? I think there's one, political commentary that one of the most important things that COVID-19 has thought is that healthcare is a global issue. I think, am I reading the same one that you read, Fabio? I think so, okay. There's one that says there's a huge area in progress on observational trials and causal analysis. This type of research uses electronic health records and allows publications of thousands of patients. In Chile, we don't have electronic records. We still use pen and paper. So do you think this is a problem in other countries? And how do you deal with this issue?
Kokila, if I could add to that, the data, the way data is collected is very different in HIC and LMIC. That's one of the issues that we face on a day-to-day basis. The kind of big databases that you get in the example for the UK, through which you can monitor outcomes in different ways. We're looking at the ICHOM outcome monitoring systems, kind of data that you can lean upon for population-based numbers, for birth defects, for example, for referral systems, which will guide policymakers, is readily available. We don't have that. And I think one of the challenges we face is that nobody really wants to fund registries. Nobody really wants to invest money in data systems because these registries or these data systems rely upon people in remote parts of the country who need to fill in those parameters, and that is often poorly done. I think it should be okay in our parts of the world to rely on best guess data. I think for a bunch of clinicians to sit together and say, listen, we're all seeing myelomeningocele very frequently. Let's start a folic acid, fortification program. That should be enough. We shouldn't have to say that across the country, so many million people were studied and this was found out. So if we have smaller studies that give an idea of where the problems is, and as Nobhojit was saying, we don't have the 2 years to wait and get authentic data and then make an intervention. There is a lot to be said for people on the ground who are seeing clinical conditions on a day-to-day basis. And I think with the global surgical community, we are at a big advantage because we've not had time to leave ORs and become desk-bound people. We still have a foot in the ORs. I think everyone that I've met is working both. It's not, we're just doing the research, we're not doing clinical work anymore. So that practical knowledge has to be valued at certain levels, and the kind of data sets that would dictate policy in HICs doesn't have to apply to LMICs.
Thank you, Lubna. I think that's very pertinent. There's two more, both themes saying that, from the pandemic, we have learned that a lot of the training, mentoring, research seminars can all be done online, where people can access them with kind of stored videos regarding training. So the world has become smaller and more accessible for education. And the one thing I've heard a lot from globally from students to say that one thing that was very positive in the pandemic is that they could access educational material from any part of the world. I think we've reached the 7:30 mark. I'd like to thank all the audience for their comments and for their participation in this program. I'd like to thank all the panelists for their time and their thoughts. And I also like to thank Lifebox for bringing this forward to us. And before